Yeah, we are live now.
Good evening, everyone. I'm Dr. Maunika from Shield Healthcare. I welcome you all for today's session. And today's topic is on fetal nervous system. And our speaker, Dr. K Sushma, MBBS, MS, OBGYN. She's a gynecologist and fetal medicine specialist. And before starting the session, I would like to give a brief introduction regarding a Shield Connect page. This is a knowledge information page where various blogs, webinars, and our leaders are the doctors from overall nation have been connected with Shield Connect page. We do a lot of newsletters and awareness programs too. This is brief introduction about Shield Connect page, and I hand over this session to Dr. Sushma for today's session.
Can you see my screen?
Yes, ma'am.
Am I audible?
Yes, ma'am, it is visible. Yes, ma'am.
Okay, and the pointer is visible, right?
Yes.
Good evening, everyone. And thank you all for joining us on this pleasant evening. I'm Dr. Sushma, gynecologist, practicing gynecologist and fetal medicine specialist from Nakrekal, Nalgonda, Sri Krishna Nursing Home. It's in Telangana. So my topic today is fetal central nervous system. Today, I'm going to talk a few basic points on the common sections of the brain. And the target audience today are gynecologists who are either new to ultrasound or who have already started doing ultrasound and who have been doing growth scans for years. Now, I hope to add a few more planes to their already existing scanning planes that they are doing. So today's topics, I'll be discussing on anatomy of fetal central nervous system, the basic planes, how to acquire them, and also few planes on extended neurosonogram, few slides on extended neurosonogram as well. And we'll discuss a few common anomalies. I'll show the slides, images of few common anomalies. And I want this session to be an interactive session. So please keep posting your comments, your doubts, and I'll keep asking certain questions. Please keep answering them. And so first we'll start with the basic planes of fetal brain. Fetal brain planes, we have axial planes are the most common planes that are taken. As we all know, fetal biparietal diameter is the most common plane that we take on in a transthalamic plane. Both BPD and HC are taken on transthalamic plane, and that is the axial plane. So the three axial planes are transthalamic, transventricular, and transcerebellar planes. We'll discuss in detail about these three planes, how to identify planes, and how to acquire these planes. What are the specific features of each and every plane? So first we'll discuss about axial, sagittal, and coronal planes. As we all know, we have axial planes. Axial planes are nothing but transverse sections. So as read in human anatomy, axial planes are transverse sections. So these are the most common planes taken even in fetal ultrasound of fetal brain. The next section we have is sagittal section. Sagittal sections divide the body into right and left halves. The other plane that we have is coronal plane. Coronal plane cuts the body from side to side. So we'll be discussing more on axial planes because those are the commonest planes. This is the image of fetal brain depicting ventricles. Here we have lateral ventricle. Fetal lateral ventricle has three parts. One is frontal horn, the other one is occipital horn, other horn is temporal horn or the lateral horn. So these three horns together join at the body or at the atrium and it forms a lateral ventricle. Two lateral ventricles on each side open through foramen of Monro into third ventricle. Third ventricle is at the level of thalamus. Third ventricle via aqueduct of Sylvius opens into fourth ventricle. And from fourth ventricle through foramen of Magendie and through foramen of Lashka, one central that is Magendie and two lateral foramens, foramen of Lashka, cerebrospinal fluid enters into subarachnoid space. And from here it continues as spinal cord, central canal in the spinal cord. So this is the basic anatomy that we need to just refresh before we move on to further slides. So the first cranial most plane, that is cranial most is one that is most closer to the cranial end of the fetus is transventricular plane. So here I have changed the direction of the fetus because this is the commonest position that we have, cephalic presentation. Commonest presentation that we have is cephalic presentation. So to be able to understand how to take the common planes, I have changed this slide into cephalic presentation. Now, as we can see here, the lowest plane is transventricular plane, the plane that is more closer to the cranial end of the fetus. This is transventricular plane. It passes through the posterior horn of the lateral ventricle and also anterior horn of the lateral ventricle. Next axial section is transthalamic plane. As you can see here, this is third ventricle. Third ventricle is nothing but cavity in between two thalamus or diencephalon. So third ventricle is nothing but it is at the level of thalamus. So a sectional plane crossing across the thalamus, across the third ventricle is transthalamic plane. Next plane that we have is transcerebellar plane. Here, as you can see here, this is cerebellum. So to get transcerebellar plane, we should move the probe caudally, but not straight down, slide it caudally or sweep it caudally, but it requires rotation of the probe in an oblique direction to get transcerebellar plane, which passes across the CSP here and through the cerebellum here. In the coming slides, we'll discuss what CSP is. First slide that I have kept here is transthalamic plane. These 2 points here these two areas here are thalami. So these two are thalami, and here the slit-like section that we see in between the thalamus is third ventricle. So the plane passing through thalamus and third ventricle is transthalamic plane. But commonly we all remember transthalamic plane by this arrow sign. So when we get this arrow sign here, this is arrow sign. When we get this arrow sign here, that is when we decide that it is in transthalamic plane, because thalami actually are not having any feature. It is actually featureless. In this is the plane where we take biparietal diameter and head circumference. Biparietal diameter we take from outer to inner, whereas head circumference we take from outer to outer of the cranial bones. So the important features that we have to see in transthalamic plane, or when we start from outside, we have to see the skin and the cranial vault. The cranial vault should be intact and is continuous. In the center, we should be able to see a midline falx. Falx cerebri, what is falx? Falx is the dura mater invagination between two cerebral hemispheres. So it is a midline structure and it is definitely seen in the midline. But as you notice, the midline falx that is present here is interrupted in between in this area. This area has a rectangular structure. This is CSP, that is cavum septum pellucidum. In further slides, we'll keep discussing about CSP. This is a very important structure and we'll discuss why it is important. So these are the landmarks of transthalamic plane. In this plane, this side is anterior, this is posterior or towards occiput. So in between anterior 1/3 and posterior 2/3, we have CSP here. CSP is a rectangular box-like structure which is interrupting the midline falx from anterior 1/3 at the junction of anterior 1/3 and posterior 2/3. This slide here is a blank slide. So I'd like to draw the main features that we see in transthalamic plane. This is the cranial vault. Here, this is posterior. This is anterior. We should see a midline falx, which is interrupted between anterior 1/3 and posterior 2/3 by cavum septum pellucidum, which is a rectangular box-like structure. And here we have an arrow sign. This is how you have to recognize transthalamic plane or BPD plane. So most of us are familiar with this plane. So having this plane as a base plane, we will move forward to learn transventricular plane and transcerebellar planes. This is transventricular plane. In transventricular plane, here we again have this structure that is CSP. CSP and the midline falx. Sorry. Okay. The midline falx here that is interrupted from anterior one at the junction of anterior 1/3 and posterior 2/3 by this rectangular box-like structure called CSP. And here, this is the posterior horn of the lateral ventricle. In transventricular plane, as we have discussed earlier, transventricular plane passes through posterior horn of the lateral ventricle and also anterior horn of the lateral ventricle. So this here is the anterior horn of the lateral ventricle. And here, this is the posterior horn of the lateral ventricle. So most important thing in fetal brain to remember is that brain is a hypoechoic structure. Hypoechoic means it appears black. Here, this is the brain parenchyma that we are seeing here. Brain parenchyma is a hypoechoic structure, whereas hyperechoic structures are the cranial vault and pia mater and dura mater, the brain coverings, they are all echogenic structures. So brain is covered by pia mater, and this lining here that we see is the pia mater that is covering the brain. This is the reason we are seeing this structure as echogenic structure. Whereas the rest of the brain tissue that we see here, the rest of the brain tissue looks hypoechoic, which is very similar to the fluid-filled ventricle. Fluid-filled ventricle is also hypoechoic structure. So, in a low resolution machine, when the margins of the ventricle are not clearly defined, then there is a high possibility that beginners can mistake the whole of the cerebral mantle and the ventricle included as ventricular diameter. So it is mistaken as ventriculomegaly. Most of the cases referred to tertiary fetal medicine centers as for second opinion as ventriculomegaly are usually normal. So this is the point that has to be taken home, that cerebral mantle is hypoechoic and is similar, very similar to ventricle, lateral ventricle, the fluid within the lateral ventricle. Here, the bright structure that we see here, this part is choroid plexus. Choroid plexus is very bright and echogenic. That is, we see it as white in color on ultrasound. Echogenic is white, whereas anechoic or hypoechoic are the structures that we see in black color. This part here is choroid plexus. This part here is posterior horn of the lateral ventricle. This part here is the cerebral cortex or cerebral mantle. And here we have anterior horn of lateral ventricle. So in transventricular plane, we can see, apart from CSP, we can see anterior horn of the CSP that is flanking the CSP on either side. And we can see the posterior horn of the lateral ventricle. But if you notice here, the lateral ventricle that has to be seen here in the near ventricle, in the near side of the probe. The probe is here. From this side, we are seeing the probe. So closer to the probe, the lateral ventricle is not seen clearly, whereas the far end, away from the probe, the lateral ventricle is seen clearly. This is because of the reverberation artifact that we get because of the bones here. So always we measure the lateral ventricle that is far side of the probe, that is on the far end of the probe. The near end ventricle is not clearly seen. So now what are the features that we saw in lateral ventricular plane? Apart from the cranial vault, the midline forks, CSP, and CSP is flanked by anterior horns of lateral ventricle. And here we can see posterior horn of lateral ventricle with choroid plexus in it and the outline of the occipital lobe of brain. And we have learned that mantle is hypoechoic. So now, I'm going to draw a transventricular plane so that it imprints in the brain, and as and when you see this plane, you should be able to diagnose and detect differentiate between normal and abnormal transventricular plane. So in the transventricular plane, as we have seen before, This is the frontal side or the anterior side. This is the occipital or the posterior side. And in between anterior 1/3 and posterior 2/3, we have cavum septum pellucidum, which is a box-like structure, which is flanked on either side by anterior horns of lateral ventricles. And here we can see occipital lobe. Within it, we can see posterior horns of lateral ventricles. And here, choroid plexus, which is brightly echogenic structure, is seen. So this picture should be imprinted in the brain, and as and when you see it, you should be able to diagnose, you should be able to differentiate the normal transventricular plane from abnormal transventricular plane as and when you see anything abnormal in this. This is how we measure ventricular diameter. In the fetal brain, intracranial structures, the structures that we measure in transthalamic plane is only BPD and head circumference. Whereas in transventricular plane, we measure the ventricular width, or also called as ventricular diameter. For that, where do we measure is really important. So can we measure it here at this level, or at this level? So anyways, in this image, you can see that it is measured between this point and this point. And why did we actually select only this point? It is because we want to measure the ventricle at the level of parieto-occipital sulcus. This is parieto-occipital sulcus, which marks the separation of occipital lobe from the parietal lobe. This side here, it is parietal lobe of the cerebral hemisphere, whereas this side here, it is the occipital lobe of the cerebral hemisphere. So this parieto-occipital sulcus, this marks the difference between, or the partition between, parietal lobe and occipital lobe. So at this point, we have to measure the diameter of lateral ventricle. And why do we choose only at this level? Because at this point, the ventricular diameter is maximum. And this is called atrium of lateral ventricle. This is the reason we have to take the measurement at the level of this dimple here, the indentation that we can see here, parieto-occipital sulcus. That is the point where we measure ventricular diameter. So the placement of cursor here is also very important. At where is the cursor to be placed? If you take the ventricular wall here, the cursor placement should be on the wall, on-to-on measurement. This is the horizontal crossbar and this is the vertical crossbar. And here also, this is the horizontal crossbar and this is the vertical crossbar. So that is how we have to place the crossbar. This is according to ISWOG guidelines. So this is the image from ISWOG website. ISWOG is International Society of Ultrasound in Obstetrics and Gynecology. So they show us how to place the cursors and where to place it. We have to measure the whole width of the ventricles, of the fluid-filled ventricles. That's why the measurement should be on-to-on. This is the ventricular wall. So it should not be on the wall, but it should be on the, not within the middle of the wall, that is. Okay, all these are wrong, whereas this is the right placement of the cursor. Next, coming to transcerebellar plane. So before we move on to transcerebellar plane, I would like to mention that the transventricular plane, the diameter that we get here, it should be less than 10 mm. Transventricular plane, any measurement within the brain should be 10 mm. That is how we have to remember. Transventricular plane should be 10 mm. Even cisterna magna should be 10 mm. And what cisterna magna is, we will get to know in the next slide. This slide here shows transcerebellar plane. In transcerebellar plane, again we have the same cranial vault. Again we have the midline forks, which is interrupted between anterior 1/3 and posterior 2/3 by CSP. And this CSP is flanked on either side by anterior horns of lateral ventricles. But here posteriorly, we can see this dumbbell-shaped structure that is cerebellum. This dumbbell-shaped structure that we can see here is cerebellum. Here in the middle, what we see here, this structure is vermis. In this particular plane, if we take the diameter, that is the transcerebellar diameter from here to here, transcerebellar diameter in mm is equivalent to gestational age in weeks. Now, for example, when we measure it from here to here, if we get it as 21 mm, that means this fetus is around approximately 21 weeks. So this is very important when you do not know the gestational age of fetus and you have a, like for example, you have a fetus which is 25 weeks by LMP and there are no early pregnancy scans until TIFA scan or anomaly scan that we do. And BPD, HC, ACFL are all very variable because it is a case of fetal growth restriction. Then the most important parameter that you can consider is transcerebellar diameter, and you have to check if transcerebellar diameter is correlating with the gestational age. The next thing after measuring transcerebellar diameter, the next measurement that we can take here is the fluid filled structure here posterior to cerebellum. This structure here that is posterior to cerebellum is called cisterna magna. This cisterna magna is important to measure because cisterna magna is very small or obliterated. It becomes narrow in cases of spina bifida, where the cerebellum is pulled down. In that way, the cisterna magna is obliterated, whereas cisterna magna is enlarged in cases of posterior fossa malformations like Dandy Walker. So this cisterna magna, the measurement should be less than 10 mm. The range is, if it is less than 2, it is spina bifida. If it is more than 10, it is Dandy Walker. Now, I'll try to draw transcerebellar plane again. This is anterior aspect, this is posterior aspect. Here we have anterior 1/3. In the anterior 1/3, we have midline falx interrupted by rectangular box like CSP. Then again in the posterior part, we have CSP. Here we have cerebellum, which is dumbbell shaped. Normal cerebellum is dumbbell shaped. And this part here is cisterna magna. This is the fluid filled structure that we have is cisterna magna. Now we are done with axial planes and now we are moving on to mid-sagittal plane. Mid-sagittal plane in the fetus, actually, as I mentioned before, there are axial planes, sagittal planes, and coronal planes. The three most important planes are only axial planes, and those three axial planes are only included in anomaly scan. When you plan to do anomaly scan in a fetus, if you look at the three axial sections, that is transcerebellar, transthalamic, and transventricular, that is enough to rule out abnormalities in the fetal brain. Now, if you want to go and do a detailed fetal neurosonogram, then we can go on and do mid-sagittal section, lateral sagittal section, and coronal sections. So we'll not be discussing all the sections except for this one mid-sagittal section because this is the next most important plane. Why? We'll discuss that. So here in this image, I have marked so many, I mean, in this image, there are so many labels. Please don't get overwhelmed with all those. So this one here, we don't have any labeling. So the one structure that I want you to focus on in mid-sagittal section is corpus callosum. This corpus callosum, this side is anterior, this side is posterior, and here we have cerebellar vermis. This is corpus callosum. Now, what is corpus callosum? Corpus callosum is a band of tissue, neuronal tissue, that connects both the cerebral hemispheres. There are two cerebral hemispheres on each side, which are connected in between by the band of neurons called corpus callosum. This band of neurons, corpus callosum, there are about the number of neurons that cross from on the midline are actually 300 million neurons that cross the midline in corpus callosum. So it is a very important structure. There is a condition called agenesis of corpus callosum where this structure is absent. So to diagnose agenesis of corpus callosum directly, we have to do a mid-sagittal section in the fetus, and that looks like this. This is the mid-sagittal section ultrasonologically that we have got. This here is corpus callosum, and this part is vermis. These are the two midline structures that we have to look at. So in a regular anomaly scan, we do not take this plane of corpus callosum. And how do we detect agenesis of corpus callosum through axial planes is by looking at CSP. So that's the reason we have given a lot of importance to CSP in all the three axial planes. We kept on repeating to take CSP in all the planes because CSP is a surrogate marker of corpus callosum. In cases of agenesis of corpus callosum, CSP is absent. So that is how, though we do not take mid-sagittal section, that is how we diagnose agenesis of corpus callosum on a regular axial plane. Now moving on to further planes, these are the planes of extended neurosonogram described in his work, but I don't want to go into these planes in detail, but in brief, these are the 4 coronal sections that we can take on the fetus. This is the frontalmost section or the anteriormost section, and this is the second section, third section that passes through the thalamus, and fourth section that passes through the cerebellum. So these are the 4 sections in the coronal sections, and this is depicting the sagittal sections. This one here is a mid-sagittal section that we have discussed just a while ago in the previous slide. This is the corpus callosum, and this here is the vermis. The next sagittal section that we have passes through the lateral ventricle, and here this is the lateral ventricle. This is the anterior horn of the lateral ventricle. This is the lateral horn of the lateral ventricle or the temporal horn, and this here is the posterior horn or the occipital horn of the lateral ventricle. This is called tri-horn view. But as I discussed before, first get familiarized with the 3 axial sections. Then these sections are very less, especially the coronal sections are not really done in a routine practice. Again, these are the 4 coronal sections that we can get, starting from the anterior most plane to the posterior most plane. But I'll move forward. So these are the ISWAG guidelines. Now this image depicts all the planes that we do in an extended neurosonogram. This here, these 3 are the axial planes that we have to focus on. Now, as and when you see these planes, you should be able to diagnose which plane it is, and you should be able to diagnose if this plane is normal or abnormal. Now, I'm going to discuss a few anomalous cases. Are you all with me? Can you please post in the comment box? Am I rushing or am I... Can you please post in the comment box? All the delegates, please, I request you.
Yes, ma'am. I have posted them to post the queries. After they post, I'll repeat.
Okay. So we got few queries so far. Dr. Maunika.
We haven't got any queries till now, ma'am. There
Okay.
were only few wishing for you. That's all.
Okay. Okay. So now we'll move on to discuss few common anomalies in fetal central nervous system. And the list of the anomalies are these. I'm going to discuss, actually, I'm not going to discuss all of these. I'm only going to show slides, images of all this at random. So the slides I'm going to discuss are these. These are the answers for the slides that I'm going to discuss. These answers I'm giving away before because I want you to predict. I want you to guess the answer. Okay. So these are the topics that I'm discussing. These are the slides that I'm going to show. One is ventriculomegaly, encephalocele, agenesis of corpus callosum, Arnold-Chiari malformation, Dandy-Walker malformation, choroid plexus cyst, holoprosencephaly, Scheissencephaly, Lissencephaly, and anencephaly. So some of these are very familiar for us, like choroid plexus cyst, anencephaly, Arnold-Chiari, and ventriculomegaly. But some of these we are not very familiar with. So when I show you the image, you please make a guess. So this first image that I'm showing here, yeah, before I move on, Dr. Maunika. Yeah, because I cannot see the comment box, I want the audience to be interactive. Yes. And please, this is a request to all the audience to please post your comments in the comment box. Are we getting any comments?
Yes, we got, ma'am, but we didn't get any queries. We are getting the comments, so we didn't get queries.
Yeah. So what I want to ask is, this is a what I want to show. Okay, this is a difficult one, so I'm going to discuss this. This is a this is CSP, and here we can see the posterior horn of the lateral ventricle. So this is a transventricular plane. And this is first thing that we have to look at is if it is a axial section or not. So this is a axial image. And this is which section? We have three axial sections as we have been discussing: transventricular, transthalamic, and transcerebellar. So now we can see posterior horn of lateral ventricle and anterior horn of lateral ventricle. So what do you think this section is? Is it transventricular or thalamic or cerebellar? So this is a transventricular plane. And here, the abnormality that we can see is there is a defect here in the full thickness of the cerebral mantle. This is a cleft that we have here, and this is called Scheissencephaly. Scheissencephaly is nothing but a full thickness cleft in the brain cortical matter, and that is lined by ventricle, that is lined by gray matter. And ventricular fluid communicates with CSF. This is Scheissencephaly. This is a new term, Scheissencephaly, new term for gynecologists, I mean. So this is very simple diagnosis, and I hope at least a few of you will post in the comment section. What is the structure that we see here? This is a transventricular plane, I'm telling you. This is a transventricular plane, and within the ventricles, these are choroid plexus. Now, can we identify what this structure is? Delegates, can you please keep posting your answers? Anybody wants to take a guess what this is that we see in the transventricular plane within the choroid plexus?
No, ma'am. No.
Nobody is typing. Okay. Okay, fine. So I'll go on. This is choroid plexus cyst. And choroid plexus cyst, if it is isolated and if it is not associated with any other major or minor structural defect, it is a common finding. It is a normal variant. But you should not call it isolated choroid plexus cyst until and unless a detailed anatomical survey has been done and there are no other abnormalities that are detected. Then only we have to call it an isolated choroid plexus cyst, and then the prognosis is very good. This case here is again a difficult one. Here you can see that the gestational age here is 32 weeks, but the brain, as you see here, doesn't have any sulcations and gyrations. So sulcations and gyrations, as we all know, there are...
Ma'am, we have an answer, ma'am.
Oh, good. Very good.
Yeah. For previous one, he mentioned choroid plexus cyst.
Okay, thank you. Thank you very much. Please keep posting your answers. So this one is a difficult one. That's why I would like to answer this. This is listen carefully, where the brain surface is bland without any sulcations and gyrations. As we all know, brain has multiple sulcations and gyrations in an adult brain. But how about fetal brain? When do we get sulcations and gyrations? So for that, I'm going to show you this next image. Here, as you can see here, initially when brain is formed, it is like a neural tube. Okay, neural tube, the way the spinal cord is formed by neural fold. Initially we have neural fold, then neural groove, and neural tube is folded upon itself. And finally we have this tubular structure. And in this tubular structure, the proximal most part, here it forms the brain. And it is divided. This one, it elongates into forebrain vesicle, midbrain vesicle, and hindbrain vesicle. And that with further development, it keeps on growing. But initially, as you can see, until about 20 weeks, there are not any sulcations and gyrations that you can see. At 20 weeks, the first sulcus that you can see here, one of the first sulci is the lateral sulcus that separates the temporal lobe from rest of the cerebral hemisphere. This is called Sylvian fissure. So these fissures are seen only starting from 20 weeks and above that. And after 20 weeks, at 6 months, you can see that there are a few more sulcations that are coming up. Here, occipital lobe and parietal lobe are separated by parieto-occipital sulcus. Here, there is central sulcus. And here, by 9 months, there are multiple sulcations and gyrations that we see here. And as we move on from young child, teenager, and adult, there are multiple sulcations and gyrations. So, fetal brain, when we do anomaly scan, we usually do it at around 20 weeks to 6 months. At this time, we do not see many sulcations and gyrations, except maybe this Sylvian fissure or the lateral sulcus that separates the temporal lobe, and also the parieto-occipital sulcus that I have mentioned before when we were talking about transventricular plane. That is the level at which we measure transventricular diameter. So these are the only sulcations and only few sulcations and gyrations that we see. So in the previous slide, I'm sorry. Yeah. So in the previous slide here, this is a 32-weeker and there are no sulcations and gyrations. So this is diagnosed as listen carefully. That means absence or absence of sulcations and gyrations. Lissencephaly is a third trimester diagnosis, and it cannot be diagnosed in second month. In second trimester during anomaly scan. So here, as you can see, the lateral sulcus that is getting deepened. Okay, this is how initially only the lateral sulcus and parieto-occipital sulcus and only few other sulcus develop. Now this is a question for everyone. Please be interactive. I want you to tell me first, what plane is it? Is it axial plane or coronal or sagittal? Dr. Maunika, can you please tell me if you have any answers in the chat box?
Yes, ma'am, we do have.
Do we have anything about this?
Yes, ma'am.
Is it axial section or is it coronal or sagittal? I think this we can all
typing, ma'am.
Okay,
that's typing, ma'am. For previous questions, most of them have answered.
Okay, thank you.
One answer C.
So just please type in if it is axial plane, coronal plane, or sagittal plane. I think this we can do after all this lecture. And also if you can find out any anomaly in this section.
Ma'am, axial plane by Aruna and another Upma Yadav axial and Alka Patil lemon sign.
Very good, very good. Yeah. So thank you all of you for your response, for being interactive. So this is axial section, and here you can see this CSP. That means this is frontal side, that is anterior side. And here we have scalloping of the frontal bones. Scalloping, that means indentation or dent of the frontal bones here that we see. And this is called lemon sign. And now, you know what is the next sign that I'm going to show now. So now quickly, I want an answer for this sign that we are seeing here. I'm also pointing out here that what we are seeing. Did we get any answers?
ONTD indirect sign.
ONTD, very good. Open neural tube defect indirect sign. And what is the sign called as? This is lemon sign and this is
banana.
Banana sign. Very good. And that is given by answer?
Alka Patil.
Okay. Thank you, Dr. Alka.
Upma Yadav.
Thank you, Dr. Upma. So this is lemon sign and banana sign. So what is the significance of these signs and why do we get these signs? So as Dr. Alka has given us the answer of open neural tube defect. In cases of spinal cord neural tube defects like spina bifida, open spina bifida, because cerebrospinal fluid is drained out and in the neural tube is dragging down and pulling down the posterior fossa structures. So cisterna magna here is obliterated. There is obliteration of cisterna magna here and cerebellum has this pull down effect, and that is the reason we get this banana sign. Because of that pulling down effect, cranial structures, intracranial contents have this negative pressure, and because of that we get this frontal scalloping that we can see here. Okay, this is called lemon sign and this is called banana sign, and we have our banana here. So these are indirect signs as mentioned by Dr. Alka. These are indirect signs because the direct sign is demonstration of spina bifida, directly seeing the lesion. these are indirect signs that give us a clue. So why do we have to rely on the indirect signs and not a direct sign like this? See, as you can see here, this is spinal cord. This is the sacral segment of the spinal cord. And here we can see it, neural tube defect. So instead of looking this and diagnosing, we can diagnose it by looking here. And why do you want to look at the indirect signs first? Because these are the first planes that we take. All of us routinely look at head for taking BPD. So that's why we have to rely more on indirect signs than direct signs like this one. So if you diagnose this one directly, if you see this one directly, this is a direct sign where you can mention that this is open neural tube defect. But if you see lemon sign and banana sign, that is giving you indirect clue and guiding you to go and look at the spine. That is telling you that you have to look at the spine right now. Okay, that is why they are called indirect signs. And that is specific for open neural tube defects. Okay, this is the next case. Now I want you to, yeah, please.
Dr. Jansi Lakshmi and Dr. Mallika Sunil Joshi have also responded as banana sign.
Okay, thank you. Thank
and
you.
Dr. Alka Patil has commenting only in 2 and try, closed NTD, no indirect signs.
Only in second trimester, closed NTD, no indirect signs.
Yes, ma'am.
Yeah. So what is the difference between open neural tube defect and a closed neural tube defect is, here you can see the defect clearly. This can be a open or a closed neural tube defect depending on if it is covered by skin or not. So this defect where meninges are seen protruding out here, if in case it is covered by a skin, then it is closed neural tube defect. In case if it is not covered by skin, then CSF is constantly being leaked out and that pull is seen. So that's why in closed neural tube defects, we cannot get those indirect signs. Whereas in open neural tube defect, we get those indirect signs. So earlier, actually, I was under the impression that closed neural tube defects do not have a surface swelling like this, but it was not correct. Open and closed are only differentiated by presence of skin. And actually, skin is difficult to make out on ultrasound. So the only thing that tells us that it is an open neural tube defect is the indirect signs that are present in brain. So we can still miss a closed neural tube defect if you only rely on the brain. Okay, so now this is the next image. Here we can see this is axial section, and here this is a mid-sagittal section. So what is it that is, which section is this in among the 3 axial sections? What do you think this is? Which plane is it? Transthalamic, transventricular, or transcerebellar? Actually, this is exactly opposite to the previous slide that we have seen. Previous one is obliteration of cisterna magna. So now this is, do we have any comments?
Not yet, ma'am. I guess doctors are typing.
Okay, we'll wait for a few more seconds.
Yes.
Okay, I'm just showing you these structures here to give you a clue on what this is.
Dr. Alka Patil has responded as transcerebellar.
Yeah, so this is transcerebellar plane, and we have splaying of these cerebral hemispheres. And here we can see cisterna magna is enlarged. There is a cystic spleen.
Enlarged cisterna magna, she have mentioned, ma'am, Dr. Alka Patil.
Yeah. So this is posterior fossa lesion with enlarged cisterna magna. So whenever you see in the axial section a posterior fossa lesion, what are all the differentials?
Doctor,
Do we have any comments?
Yes, ma'am. Aruna Sallu, she has
Okay,
mentioned
ma'am.
like.
Yes, doctors are typing.
Okay, we'll wait for a few.
Ma'am?
Yeah.
Dr. Aruna Sallu has mentioned transventricular.
Okay, maybe this one here looked like a transventricular plane, but thank you for typing. But yeah, this is actually transcerebellar plane. These are the cerebral hemispheres that are splayed out instead of the regular dumbbell shape that we have here. These cerebral hemispheres are splayed out because of the cystic lesion that we have here. And this cystic lesion, whenever you see a cystic lesion in the posterior fossa, we have to look at the mid-sagittal section of the fetal brain. And here we can see this is the posterior part, this is the anterior part. And I'm sorry, we cannot see the CSP clearly in this brain, but here this is vermis. Vermis should be here like this, vertically oriented, whereas here it is horizontally oriented because the cystic lesion here is pushing it up. And this diagnosis here is, what do you think the diagnosis here is? I have already mentioned all the diagnosis in the first slide before I started these images.
Ma'am, vermis, by Dr. Alka Patil.
Yeah, this is vermis. Yes, that is true. Vermis is very echogenic structure. And this vermis, instead of being like this vertical, it is actually transversely placed because it is pushed by the fluid filled content here. So this, I'll give a few seconds if anyone wants to type the diagnosis. This is, okay, did we get any comments?
Yes, ma'am. Back pouch cyst by Dr. Alka Patil.
Blake's pouch cyst. Okay. So thank you for the diagnosis.
And Dandy Walker by Dr.
Right?
Aruna Sallu.
Okay. So this is actually Dandy Walker, not Blake's pouch. So the differentiating point here between Blake's pouch and Dandy Walker is, in Blake's pouch, vermis is not rotated like this. Vermis, instead of being vertical like this, is rotated to a transverse or a horizontal axis. So this rotation here occurs because it does not occur in Blake. Actually, the rotation is very minimal in Blake's pouch cyst at around 20 degrees, whereas in Dandy Walker, the rotation is very much. And here there is also tentorial elevation.
Ma'am, we do have more answers from our delegates.
Yes, please.
By Mallika Sunil Joshi, Dandy Walker.
Yeah.
And Rupapati, equiductal stenosis.
Equiductal stenosis. Actually, posterior fossa lesions, what we have are Blake's pouch cyst, Vermian hypoplasia, and Dandy Walker malformations. These three are the differential diagnosis in cases of posterior fossa cyst. So in Dandy Walker, the vermis appears like a rat tail, as you can see here. This rat tail appearance is specific to Dandy Walker, and the degree of Vermian rotation is also very huge in Dandy Walker, and this is the most severe form. Whereas in Blake's pouch cyst, the rotation is very minimal. Very minimal rotation will be there, and that is actually it does not have any neurological consequences, Blake's pouch. Whereas Dandy Walker has significant neurological complications. In aqueductal stenosis, we have that case also. We'll get there. Now I'm moving on to next slide, which is very easy one. I want so many comments for this section, for this image. We have two images. Both are from different patients, but the diagnosis is same. Dr. Monica, please give them few minutes until they type.
Yes, ma'am.
Please don't read out the answer, but just let me know how many answers did we get so far.
Okay, ma'am. One we got.
Only one.
Yes,
We'll wait for a few more answers. I don't want if it is axial, coronal or sagittal. I don't want which plane it is, transventricular, thalamic or cerebellar. I only want a direct diagnosis because this is a straightforward image.
ma'am, we got two more.
Okay, we'll wait for few more. We'll see how many people will respond to it. So far, we got 3 people answering this. I want so many more answers. As it is a very straightforward case, as you all
Ma'am,
can.
we got more one we got.
Okay. Okay.
Total 4
Okay.
answers we got.
Okay, please, can you please read them out?
Yes, ma'am. Meningococcal myelocele.
Meningomyelocele, okay.
Different but arachnoid and black pouch cyst.
Arachnoid and black pouch, okay.
And encephalocele.
Encephalocele.
Ventriculomegaly.
Ventriculomegaly.
And another doctor, Jeevan Jyoti, also responded encephalocele only.
Encephalocele. Yeah, so encephalocele is the right answer, but we also have in this image ventriculomegaly here. So here also we have the defect in the cranium with the structures, intracranial structures protruding out. And here in this defect, this is a very large defect in the second image that we can see the intracranial structures protruding. Not only the intracranial structures protruding, but also the ventricles also are protruding. This is a special variety of encephalocele called encephalocystocele, where even the ventricles are protruding into the encephalocele. So yeah, ventriculomegaly is also there, but the cause of ventriculomegaly here is encephalocele. This is the next case. This should be an easy one. Please post in your answers. Or those of you who think the answer is too easy, please post in what all you are seeing. What are all the features that you are seeing in this case? This is a straightforward diagnosis.
We got one answer, ma'am.
Yeah, can you please read it?
By Dr. Alka Patil.
Yeah.
Meningomyelocele.
I think that was for the previous meningomyelocele.
Yes.
I mean, okay, maybe that was for the previous one. For this one, we want, this is the axial section of the fetal brain. Meningomyelocele is open neural tube defect of spinal cord. Whereas if you see the defect of the brain, we call it encephalocele or meningoencephalocele.
Ma'am, we have few more answers.
Yeah, please.
By Dr. Upma Yadav, ventriculomegaly.
Yes.
And Dr. Aruna Sallu, ventriculomegaly.
Yeah.
And Dr. Alka Patil, tear-shaped lay ventricle absent CSP.
Actually, we actually have the CSP here. I know why it is looking confusing. I want those of you who have typed ventriculomegaly, that is the right answer. So I want you to go in detail and let me know what are all the features that you are seeing here to detect it as ventriculomegaly.
And we do have 3 answers from Dr. Jeevan Jyoti.
Yes.
Mallika Sunil Joshi as ventriculomegaly,
Yeah.
and Dr. Priyanka encephalocy.
Okay, so this is actually a case of ventriculomegaly. Thank you everyone for answering. So here we can see this is a transventricular plane, where here we can see the rectangular box like CSP here, which is flanked on either side by anterior horn of the lateral ventricle. And here we can see the posterior horn of the lateral ventricle. But here the striking feature, one more feature that we are seeing here is there is one more hypoechoic area here. Maybe that has caused the confusion that CSP is absent, but no CSP is actually present. Then what is this? Here we can see the posterior horn is dilated, and also here, as you can see, the anterior horn is also dilated on both the sides. And we can see the near ventricle also posterior horn that is dilated. But what is this structure that we can see here? This is actually, okay, I'll give a few seconds if anyone wants to answer. Did we get any answers, Dr. Monica?
Not yet, ma'am. We'll wait for a few seconds.
Okay. Okay, shall I give the answer?
Yes, ma'am. We didn't get any answers now.
Okay, so this structure here that we can see here is the third ventricle. Third ventricle is also dilated. So usually ventriculomegaly means we measure the distance, we measure the posterior horn at the level of the parieto-occipital sulcus. We measure the atrium of the lateral ventricle. And if it is more than 10 mm, we call it ventriculomegaly. Here, not only the posterior horn is dilated, the anterior horn is also dilated, and the third ventricle is also.
Ma'am, one answer is there.
Yeah, please.
Tear-shaped dilated third ventricle.
Yeah, tear-shaped. This is not tear-shaped, please. We'll go there. We'll go there.
Dilated third ventricle.
Yeah, this is dilated third ventricle actually. So why do we have dilated third ventricle when there is no tear shape also? So because of aqueductal stenosis actually. In case of aqueductal stenosis, not only both the lateral ventricles are dilated, but the third ventricle, which drains into fourth ventricle via aqueduct, is also dilated. So that's the reason third ventricle is dilated here. So this is a case of aqueductal stenosis. Now we'll move on to next question. Yeah, this is a first trimester fetus. So this is a very straightforward diagnosis. I want beginners to try attempting this. Please do try attempting this, whatever you say, even if it is wrong, please post in your answers. How many answers did we get, Dr. Monica?
No, ma'am, we didn't get
No
any
answers yet.
No answers yet.
Oh, okay, we'll wait for a few more seconds. This is a very simple and straightforward diagnosis. This is a first trimester fetus at the time of NT scan, or even prior actually, even prior to, yeah, at around 11 weeks, right?
We got 2 answers, ma'am, 3 answers.
Okay, we'll wait for a few more seconds. We'll wait for a few more seconds. We want more answers, more people to attempt. See, okay, whatever you are thinking, please post it, whatever you call it. Please type in your answers. I want more people to try attempting whatever it is. Even if you want to say it is normal, please type it as normal. Or describe the abnormality that you think it is. Did we get any more answers?
One more, ma'am.
Okay. Yeah, can you please read out the answers?
Dr. Mallika Sunil Joshi, anencephaly.
Yeah.
Dr. Alka Patil, anencephaly. Dr. Upma Yadav, anencephaly.
Okay. And the fourth one, you said 4.
Same thing, same
Okay.
doctor, ma'am, Alka Patil. Dr. Holoprosencephaly.
Holoprosencephaly. Okay, good. Thank you. So this is actually here what we can see here is a mid-sagittal section of fetus, not a perfect mid-sagittal section, but a sagittal section. Okay. So here we can see that in the sagittal section, this part of brain here is protruding out. It is not the normal shape that we are supposed to see, maybe around here that we are supposed to see, but this part here is protruding out, and this is because of the absence of cranial vault. Because of the absence of cranial vault, so as you know, anencephaly is a second trimester finding, whereas in first trimester finding, we only have acrania. So yeah, we can say it as anencephaly. So anencephaly is actually a spectrum. Initially, it starts as acrania. That means the initial defect that the fetus has is not absence of brain tissue, but only absence of the calvarium or the bony structure that is covering the brain tissue. So initially, when the bony structure is absent, the bulk of the fetal brain is seen protruding out into the amniotic fluid. And gradually it starts eroding, and finally all the brain gets eroded, and only the basal, only the brain stem is present, and then we can call it anencephaly. Yes, anencephaly is the right diagnosis. Now coming to holoprosencephaly, holoprosencephaly is not a diagnosis that we make in the sagittal section. Okay, so this is anencephaly. This is the finding that we see here is the protrusion of the fetal brain, abnormal protrusion of the brain structure because of the absence of the calvarium. So anencephaly is right answer for this. We'll move on to next slide. Please post your comments, remarks, or diagnosis, whatever you think it is. If you think it is normal, if you think it is what, or at least what section you think it is, what plane, or actually, I will tell you what plane this is. This is actually a transventricular plane. But one important structure that we have to see, that I have been stressing upon from my first slide onwards, is missing in this. One most important structure that we have to see in each and every axial section is missing here. And please type in the chat box, what is the structure that is missing? In all the 3 axial planes, we have to look at that one structure, and that one structure is missing here. And why is that one structure important to see in all the 3 axial planes? Dr. Maunika, are we getting any answer?
One answer, ma'am.
Only one answer so far. So I want everybody to keep attempting this. What is the one important structure that I have been?
3 more answers we got, ma'am.
Okay, good. Thank you. Yeah, please.
4. All of them answered CSP is absent.
Yes. Correct. Okay. And only that is the answer that we got?
And one Dr. Priyanka, ACC.
Yes, ACC is agencies of corpus callosum. So CSP is a very important structure that we look at in all the 3 axial planes, that we make sure to look at in all the 3 axial planes, because it has to be seen to diagnose agenesis of corpus callosum. We have to see it to rule out ACC and to diagnose that corpus callosum is normal.
Two more answers we got, ma'am.
Yes, please.
One is corpus callosum agenesis.
Yeah.
And by Mallika Sunil Joshi, doctor, and Dr. Upma Yadav, falx cerebri.
Falx cerebri. Falx cerebri is this midline structure that we can see here. This midline structure is uninterrupted in this case. So the rectangular box-like structure that we have to see after the interruption of this falx is absent. We can see two lines that are on either side of this falx. These two lines are not CSP, but these are medial border of the frontal lobe of the cerebral hemisphere. This is the frontal lobe, and this is the frontal lobe, and this is the medial border of the cerebral hemispheres that we can see here. But these two cerebral hemispheres that are to be connected by CSP are not connected together. So here you can see this is the anterior horn of lateral ventricle, and here this is the anterior horn of the lateral ventricle, which are to be flanking on either side of the CSP like this, are very far away from the midline. And they also take up the shape of these ventricles here, they take the shape of teardrop. This teardrop sign is characteristic of agenesis of corpus callosum. Why do we get this teardrop sign here? Teardrop is because the usual finger-like projection kind of thing that we have to get is actually pinched out here, and it becomes narrowed and like a teardrop. It is pinched out by the Probst bundles that are here. These are the neurons that are supposed to cross here, but they are not crossing, and they form a bulge here and they press on the anterior horn. And that's the reason this is pinched up and this appears in the form of teardrop. Okay, this explanation is not needed. Just remember that teardrop sign is seen in agenesis of corpus callosum, and absent CSP is the hallmark. These are indirect signs of agenesis of corpus callosum. Now this is one more slide. We only have, I think, 1 or 2 slides. We'll quickly wind up. So please quickly answer this. What is missing in this plane? This is the axial section. The most important structure that is missing here is, what do you think is missing here? The most important structure that is even more important than CSP is missing here. Did we get any answers, Dr. Monica?
No, ma'am. Not yet.
Okay. This is a axial section, and what don't we have in this section that we normally see in an axial section? What is the diagnosis that you think it is? We'll wait for a few more seconds and we'll go ahead.
Yes, ma'am. We got 2 answers.
Okay, please read it out.
Dr. Alka Patil, falx cerebri.
Very good, yes.
Dr. Mallika Sunil Joshi, falx cerebri.
Yes, so CSP interrupts falx cerebri, but here there is no CSP, of course, but there is no falx cerebri as well. So falx cerebri is absent. So what do you think the diagnosis is?
Hollow prosencephaly.
Yes.
By Dr. Alka Patil and Dr. Mallika Sunil Joshi also same answer, ma'am.
Okay, thank you very much. So the midline structure itself is absent here. Why do you think the falx is absent? The falx is absent because there is no midline here. That means there are no 2 cerebral hemispheres. There is only one single cerebral hemisphere that is there, or I don't know if you can call it cerebral hemisphere, but there is only one single hemisphere. Hemisphere we call it when there are 2 spheres. Hemi is one side and other hemi is another side. So it is a whole structure And this structure is a prosencephalon. Prosencephalon, mesencephalon, and telencephalon are the three vesicles that we have for forebrain, midbrain, and hindbrain. Forebrain vesicle is prosencephalon. So this prosencephalon is intact like a whole. It is as a whole, which is not divided into hemispheres, whereas it is whole. That's why it is called holoprosencephaly. The hallmark of this is that the midline falx itself is absent. So to understand holoprosencephaly, I have just kept few slides on embryology. So no need to go into too many details of this. But here, as we can see, there are three brain vesicles: forebrain, midbrain, and hindbrain. The forebrain vesicle is called prosencephalon. So this prosencephalon, instead of dividing into two like this, it is whole like this. So it is a holoprosencephaly. And this slide, I think I kept it for anencephaly. So this is anencephaly, the formation of neural tube. This is the fetal pole that we have. So initially neural tube is formed by two neural folds are seen on either side. These two neural folds fuse in the center and they close cranially and caudally. So cranially, this is the anterior neuropore. Here, if it doesn't close cranially, this part, if it doesn't close, we get anencephaly. And here, the caudal part, if it doesn't close, it is spina bifida. The whole thing, if it doesn't close, this is a very severe form of the spectrum that is called craniorachischisis. Okay, these slides are only, these are video clips. These are all normal video clips, but I want you to tell me what are the planes. These are very, very basic. After doing all the anomalies, just mention, okay, what is the plane that we got here? What plane is it? This is axial section. This is a normal section. And what among the three axial sections is this? Please quickly answer so that we can go and finish this quickly. What is this section? We have three axial sections, as you all know: transthalamic, transventricular, and transcerebellar. So what section is this? Monica, Dr. Monica, did we get any answer?
Yes, ma'am. No, ma'am, not yet.
Not yet. Okay. So what plane is this? So this is a quick revision of the first few slides that we have done. And I don't think most of you even need this because you are already good at answering anomalies. No answers yet?
No, ma'am, not yet.
So is
yes,
this?
ma'am, we got.
Yeah, this is?
Transthalamic by Dr. Priyanka.
Okay, thank you. Next, did we get anyone else?
No, only one answer.
Okay, so actually we can also see here, though we can see thalamus.
Transventricular by Dr. Aruna, ma'am.
Yeah, so here we can see thalami, but also here the most important thing that we can see here is the posterior horn of lateral ventricle. So this is actually transventricular plane also, but it can pass off as a transthalamic plane also. Okay, so this one is a transthalamic plane where we got this arrow sign.
Yes, ma'am. We got two answers. Transventricular by Dr. Mallika Sunil Joshi and Dr. Alka Patil.
Yeah. So here, what is this plane again? This is the same as we have seen before, that is transventricular. Now the next one, here we got axial sections. This is arrow sign, that is transthalamic. So as you are noticing, in all the sections, we have to focus if CSP is present. This is a rectangular box-like structure which is longer than wider. CSP ratio also we take, that is the length to width ratio. Length always should be longer than the width. So here, I want to show you a few sections, and just please tell me what section is this, and do you think it is a perfect section? Is this a perfect section? We can see an arrow sign here. So what section do you think it is? And do you think it is a perfect section? Did we get any answers, Dr. Monica?
No, ma'am.
Not yet. Okay. What plane is this? And do you think it is perfect?
Answer is no, ma'am.
No, it's not a perfect plane. Okay.
By Dr. Alka Patil.
Yeah. Why is it not a perfect plane? Because we don't have a CSP here.
Yes.
Okay. This is a transthalamic plane and it is not a perfect plane. The next next bookmark. Yeah. Do you think this is the perfect plane? Yes or no? Please, quick answer. Yes or no? Do you think this is a perfect plane?
Transthalamic, not perfect.
Not perfect still. Can't we see this? But still it is not perfect. Yes, that is the right answer, that it is not a perfect plane because the midline forks is not interrupted. And what we are seeing here, this is not CSP, but one step below the CSP level, we get this by columns of fornix. One thing that I want you to remember is in the CSP plane, midline fork should always be interrupted. Only then can you know that CSP is normal and you can infer that corpus callosum is normal. So from this plane, we cannot infer that CSP and corpus callosum is normal. So now, is this a perfect plane? Are you happy with this plane? Or do you want me to go on to the next bookmark? Yeah. So this bookmark, is everyone happy with this plane?
CSP should be seen.
Yeah.
Dr.
So this is the perfect CSP that you want to get. This is the rectangular CSP, and which is flanked on either side by lateral ventricles, anterior horn of lateral ventricle. And in the posterior part of CSP, we can also see columns of fornix, but this is okay. I mean, this is the right plane. Now, quickly, which plane is this? Which plane is this? This will be our last slide. Did we get any answers, Dr. Monica?
Not yet.
Which plane is this, and is this a perfect plane?
Transcerebellar by Dr. Priyanka.
Yeah.
Transcerebellar by Dr. Alka Patil.
So, yeah. Thank you very much. Thank you all the delegates for joining in, and very special thanks to all the delegates who have answered. Can you please read out the names once?
Yes.
Just the names of the delegates who have actively participated.
Dr. Upma Yadav, Dr. Aruna Sallu, Dr. Alka Patil, Dr. Rupapati, Dr. Priyanka, Dr. Mallika Sunil Joshi, yes, ma'am.
You forgot mentioning Dr. Jeevan Jyoti.
Yes, ma'am. Dr. Jeevan Jyoti.
Yeah. Thank you all the delegates for answering. Are there any doubts, queries posted?
No, ma'am. Queries are not posted. Dear delegates, kindly post your queries. We can discuss with madam.
Yeah, we'll
And
wait.
Dr. Swati also, ma'am.
Okay. Thank you very much, each of you, for being so sportive and being interactive. I wish I could see the comments.
Dr. K Pallavi, ma'am.
Okay. So if you don't have, we'll wait for a 1 or
Yes,
2
ma'am.
minutes and we'll wrap up the session. It's already past 9.
Yes, ma'am. We don't have questions, but we have few feedbacks that this is an amazing session by Dr. Mallika Sunil Joshi.
Thank you. Thank you, doctor.
Ma'am, we'll wait for 5 to 10 seconds, and if there are no queries, we can close the session.
Yes, thank you. Yeah, we'll do that.
Ma'am, I guess we don't have any queries.
Yeah.
And thank you so much, ma'am, for taking out your time and giving a detailed explanation. Most of the doctors has involved, and they might be learning new things. Even I have learned new things today. And thank you, delegates who have actively participated and actively answered each and every question. And thank you so much for spending time on this session. I would like to have these sessions in future with Dr. Sushma, ma'am. Thank you so much for your time, ma'am.
Yeah, thank you, Dr. Monica. Thank you very much.
Thank you, ma'am.
And thank you, Shield Connect, for giving me this opportunity.
Thank you so much, ma'am.